My name is Terry Mamounas. I'm a breast surgical oncologist. I'm the director of the Comprehensive Breast Program at UF Health Cancer Center at Orlando Health in Orlando, Florida. What are the options of reconstruction after mastectomy? What are some of the advantages and disadvantages of immediate versus delayed reconstruction? Well, I'll start by saying that mastectomies of today are different than mastectomies in the years past. We started with radical mastectomy, which was a very invasive procedure, removing muscle, skin, nodes, all unblocked. Then we transitioned to modified radical mastectomy or total mastectomy. And more recently, we performed more cosmetic mastectomies, such as the skin-sparing mastectomies, which we preserve the skin envelope of the breast, but we do remove the nipple areola complex. And even more importantly, nipple-sparing mastectomies, which is a total skin-sparing mastectomy, where the whole skin of the breast and the nipple is preserved. So starting from that standpoint, we can perform more cosmetic mastectomies with, of course, breast reconstruction. Now, there are several options of reconstruction. Let me first address when is the best time to do the reconstruction, immediate or delayed. We tend to do the reconstructions in an immediate fashion, or what we call immediate delayed, meaning that we start the reconstruction process at the time of a mastectomy, and then the reconstruction is completed over 2 or 3 stages. For example, the most typical approach, the first go around when we do the mastectomy, is to have the plastic surgeons insert an expander in the area of the skin envelope. In other words, we'll preserve all the skin, and then we'll put an expander as a temporary hold so we can stretch the skin a little bit and give the patient a mount, even at the time of her first surgery. Now, that expander is filled with saline, and eventually that gets inflated to a volume that the patient is happy about. And then eventually that gets either exchanged for an implant at a later time, which is one form of reconstruction. Silicone implants is usually what we use. This, as you know, there has been some controversy. They have been disapproved by the FDA and then reapproved. And at the end of the day, they were found to be very safe. So now silicone implants is what we recommend and do for patients. So the patients can opt for implant-based reconstruction, and sometimes this can be bilateral, of course, if we have bilateral mastectomy, and that performed on the 2nd stage. And on the 3rd stage, then patients can have nipple reconstruction if the nipple has been removed. If obviously they have a nipple-sparing mastectomy, there's no need for the 3rd phase. On the 2nd phase, the expander is removed, and then the implant is placed with a small procedure. That's one form of reconstruction. A second form is to use autologous tissue reconstruction. So use the patient's own tissue. Usually the most common one nowadays is the DIEP flap, or deep inferior epigastric flap, which is taking tissue from the stomach, from the abdominal area. This is skin and subcutaneous tissue, but not the muscles anymore, and bring this tissue into the breast and hook vessels from the tissue to vessels in the breast area. The internal mammary usually is what they use to vascularize the flap. And this is what we call a DIEP reconstruction. The advantages of that is that it uses the patient's own tissue, so there is no foreign body such as an implant. And this is very appealing sometimes for patients that may need radiotherapy, where the implant-based reconstruction is fraught sometimes with capsular contraction and potentially asymmetry between the 2 breasts. So if radiation is it needs to be given, then autologous reconstruction appears to be more beneficial because there's no foreign body. So the same approach is used in those patients. Typically, you still get the expander placed at the time of the mastectomy, the unilateral or bilateral mastectomy, and then at the later phase, after any other treatment is given for breast cancer patients, then we complete the reconstruction with the autologous tissue. We remove the expanders and put the autologous tissue. Occasionally, what we have done also is for example, a patient may undergo a nipple-sparing mastectomy, and in a short interval thereafter, in other words, we don't start the reconstruction at the time, just do the mastectomy alone, and within a week or 2 weeks, then the patient undergoes a DIEP-based reconstruction. autologous reconstruction. And the reason for that sometimes is to ensure the viability of the nipples after the nipple sparing mastectomy, to ensure very good healing, and then in a short interval, you proceed and with the second phase of reconstruction, or first in that case. And what the advantage of that is that you don't have to undergo the expanders placed, or wait for a few months, and then do the autologous reconstruction later on. You can do it essentially in one phase. There are two procedures, but the first procedure is the mastectomy, and the second is the autologous-based reconstruction. So the pros and cons of each approach, and we individualize, of course, depending on the situation. For prophylactic mastectomies, for example, for BRCA mutations or other high-risk situations, implant-based reconstruction is more common because there are no additional treatments. There's no radiation or chemotherapy involved in the decision. So the patient gets the expanders, and then eventually implant-based reconstruction happens a few months later. But for patients with breast cancer, particularly when radiation is involved, then we tend to also discuss the option of autologous reconstruction for patients that need it.